You wake up every morning, swallow that small pill with a sip of water, and trust that it's protecting you. Your blood pressure numbers look decent at your last appointment. Your doctor seems satisfied. So why are you still exhausted before noon? Why does climbing a single flight of stairs leave you gasping? Why is the weight piling on around your middle no matter what you eat? Here is what nobody has told you yet, and what I'm going to show you today with real clinical data. There is a very real chance that the medication you are faithfully taking every single morning is not protecting you. It may actually be the thing quietly working against you. And the most unsettling part? Millions of doctors are still prescribing it the exact same way they did 30 years ago, even though the science has moved on dramatically. I am Dr. Alan Mandell, and this channel exists for one reason, and to take the most current, evidence-based research on senior health and bring it to you in plain language that you can actually use. If you are over 60 and you are managing your blood pressure with a daily pill, what I am about to share with you could completely change the conversation at your next doctor's appointment. Stay with me because this one matters. Let us talk about beta blockers. You probably recognize them by their brand names: Toprol, Tenormin, or Lopressor, or maybe by their generic names, metoprolol and atenolol. These medications have been prescribed for high blood pressure for over 5 decades. Every single year, doctors across the United States write tens of millions of prescriptions for them. They are inexpensive. They are familiar. Physicians have been writing that prescription since medical school, and for a very long time, they were considered the gold standard for treating hypertension, the default choice, the safe bet. Here's the problem that nobody is talking about loudly enough. The research has moved on significantly, and for many seniors living with uncomplicated high blood pressure, meaning elevated blood pressure without an accompanying cardiac condition, beta blockers are no longer the best choice available. In fact, they may be making several critical things worse at the exact same time they are bringing your numbers down on that cuff. Let me explain exactly what a beta blocker is doing inside your body, because this matters. Your heart has receptors sitting on its surface. Think of them like locks on a door. Adrenaline is the key that fits perfectly into those locks. When adrenaline connects, your heart beats faster and with more force. Beta blockers work by sitting inside those locks, so the adrenaline cannot get in at all. That slows your heart rate, reduces the force of each beat, and brings blood pressure down. On paper, that sounds completely reasonable. And for certain serious cardiac conditions, recovering from a heart attack, managing heart failure, treating dangerous arrhythmias, beta blockers are genuinely life-saving medications. Nobody is questioning their value in those specific situations. That is not what we are talking about today. What we are talking about is using these medications as the primary treatment for run-of-the-mill high blood pressure in otherwise healthy seniors. And on that specific question, the evidence has shifted in a way that should have changed prescribing habits across the country, but largely has not. The turning point came with one of the most significant hypertension trials ever conducted. It is called the ASCOT trial, the Anglo-Scandinavian Cardiac Outcomes trial, and it was published in the prestigious medical journal, The Lancet. This was not a small study. It followed over 19,000 patients with high blood pressure and compared two groups directly against each other. One group was taking a beta blocker combined with a diuretic, the traditional approach. The other group was taking a calcium channel blocker combined with an ACE inhibitor, the newer alternative. The trial was stopped early, not because something went wrong, but because the results were so clear that researchers decided it would be ethically wrong to keep going. The group on beta blockers had significantly more strokes, significantly more heart attacks, and a dramatically higher number of new diabetes diagnoses. The calcium channel blocker group experienced 23% fewer major cardiovascular events. 23%. That is not a rounding error. That is not a minor statistical fluctuation. That is a massive, clinically meaningful difference that should have sent shockwaves through cardiology practices everywhere. It did in some places. Following Ascot and other confirming studies that came after it, the United Kingdom's National Institute for Health and Care Excellence, one of the most respected medical guideline bodies in the world, formally removed beta blockers from their recommended first-line treatments for hypertension. They are no longer the preferred choice in British clinical guidelines. The evidence was too clear to ignore. Yet millions of Americans remain on them as their primary blood pressure medication, often on a prescription that was written years ago by a doctor who has since retired or moved on, and nobody has ever sat down and asked whether that decision still makes sense today. Right now, pause for just a second and think about this. When was the last time your doctor actually reviewed why you are on your specific blood pressure medication? If you cannot remember, keep watching, because what comes next is exactly what you need. Now let me walk you through the specific ways these medications may be working against you, particularly if you are over 60, because age changes everything about this calculation. The first issue is fatigue and exercise intolerance, and this one is more significant than most physicians take the time to explain. When you block the adrenaline receptors in your heart, you place a hard ceiling on how high your heart rate can climb. For a 40-year-old sitting at a desk for most of the day, that ceiling might feel completely invisible. They may never come anywhere near it. But for a 65-year-old who wants to walk around the neighborhood, after dinner, swim a few laps, work in the garden, or keep up with their grandchildren, that limitation is not invisible at all. You hit a wall faster than you should. You feel winded earlier. Your legs feel heavier. Exercise feels disproportionately hard for the effort you are putting in. And here is where the real damage quietly accumulates. Physical activity is one of the most powerful tools we have available for naturally lowering blood pressure. Study after study has confirmed this. When beta blockers make exercise feel harder, less enjoyable, and more discouraging, people naturally do less of it. Less physical activity means blood pressure stays elevated, which means the medication is not actually solving the problem it was meant to solve, and the lifestyle intervention that would genuinely help becomes increasingly out of reach. Let me tell you about Harold. Harold was 71 years old when he came in for an appointment and reported fatigue so profound, so relentless, that he had stopped his evening walks entirely. He had been on atenolol for 3 years. In that time, he had gained 14 pounds. His fasting blood sugar had drifted into pre-diabetic territory, and his energy, in his own words, felt like running on half a tank every single day. His previous physician had told him this was simply aging. When we reviewed his medication alongside the current evidence, the picture became considerably clearer. The second major concern is metabolic damage, and this one is extensively documented in the medical literature. Beta blockers increase insulin resistance. They raise triglycerides. They lower HDL, your protective so-called good cholesterol. A comprehensive meta-analysis published in the Journal of the American College of Cardiology found that patients taking beta blockers had a 22% higher risk of developing type 2 diabetes compared to patients on other antihypertensive medications. 22% higher risk from the very medication that was supposed to be protecting their health. For seniors who are already managing blood sugar carefully, or who are sitting in that gray zone of prediabetes, that is a significant and entirely unnecessary risk being layered onto their daily life by a medication that is not even outperforming its alternatives. Here is what genuinely struck me when I worked through this data carefully. Beta blockers often do bring your blood pressure numbers down. The reading on the cuff looks acceptable. Your doctor glances at 128/76 and feels satisfied. The problem is what is happening underneath that number, the metabolic disruption continuing quietly below the surface. The cardiovascular risk accumulating, the slow, steady erosion of your energy, your metabolic health, and your quality of life. You can show a perfectly acceptable blood pressure reading and still be accumulating harm if the medication achieving that reading is simultaneously working against your body's broader health. The third concern is fall risk, And this one is critically underappreciated in older adults with consequences that can be genuinely catastrophic. Beta blockers can cause orthostatic hypotension, a sudden significant drop in blood pressure when you stand up from a seated or lying position, that brief dizzy or lightheaded feeling when you rise from your chair or get up from bed in the morning. For a younger person, it is mildly annoying. For a 73-year-old, it is not just uncomfortable, it is a fracture waiting to happen. Hip fractures in adults over 70 carry a one-year mortality rate approaching 30%. A medication-induced fall is not just a fall, it is a life-altering event with devastating potential consequences, and it is entirely possible that the medication causing it does not need to be the medication that person is on at all. Now, before I tell you what the research actually supports as better options, I need to pause and say something that could genuinely protect your life. Please do not skip this part. Never stop a beta blocker on your own without medical supervision. Stopping abruptly can trigger a dangerous rebound effect that causes your heart rate and blood pressure to spike rapidly and uncontrollably. In some cases, this rebound has triggered heart attacks and serious, life-threatening arrhythmias. Any transition away from these medications must be supervised directly by a physician and must be done gradually over several weeks on a carefully managed schedule. What I am giving you today is information, current evidence, and specific questions to bring to your doctor, not permission to open your medicine cabinet and make changes on your own. Please take that seriously. Now, what does the current evidence actually support as superior alternatives for seniors with uncomplicated hypertension? Two medication classes stand out with consistent, compelling data behind them. The first is calcium channel blockers. Amlodipine is the most widely prescribed in this class. The ASCOT data strongly and clearly favored this class over beta blockers in the primary prevention of cardiovascular events. It does not carry the same metabolic risks. It does not impose the same ceiling on exercise capacity. And a large, well-designed analysis published in the British Medical Journal specifically confirmed that amlodipine was associated with significantly lower stroke risk compared to atenolol in elderly hypertensive patients. That is exactly the population we are discussing. The second strong alternative is ACE inhibitors and their related class, ARBs, angiotensin receptor blockers. Medications like lisinopril, ramipril, losartan, and olmesartan have shown consistent benefit in senior populations, with protective effects for kidney function, improved outcomes in patients managing diabetes, and a considerably more favorable fall risk profile. One important note: ACE inhibitors do cause a persistent, dry, often irritating cough in roughly 10 to 15% of patients. If that is you, an ARB is generally the better choice and works through a similar mechanism without triggering that side effect. Let me tell you about Dorothy. Dorothy was 74 years old when her cardiologist revisited her long-standing beta blocker prescription and made the decision to transition her gradually over 8 carefully supervised weeks to a combination of amlodipine and losartan. Within 3 months, her fasting blood sugar had normalized completely. She lost 7 pounds without making any intentional changes to her diet, and she described in a follow-up appointment feeling like herself again for the first time in years. Her blood pressure readings, importantly, were actually more consistent, not less. Better outcomes on every single measure that matters. So here is exactly what you should do with everything you have just learned. These are your 5 concrete action steps. First, look at your current medications today and identify whether you are taking a beta blocker specifically and exclusively for blood pressure, not for a diagnosed heart rhythm. Disorder, not for post-heart attack management, not for heart failure, but purely for hypertension. The names to look for are metoprolol, atenolol, bisoprolol, propranolol, and carvedilol. Second, write down 3 specific questions before your next appointment, and bring that paper with you. Ask your doctor, Was my beta blocker prescribed specifically for hypertension, and does that prescription still reflect what current evidence-based guidelines recommend? Ask, have we evaluated my fasting insulin and triglyceride levels recently, and what do those results actually mean for my overall risk? And ask, based on my complete health picture, would I be a reasonable candidate for transitioning to a calcium channel blocker or an ARB? Third, request a formal medication review. If you have been on the same blood pressure medication for more than 2 to 3 years without a systematic reassessment, you have every right to ask for one. Many seniors across the country are currently taking medications that were considered standard of care in 2005 and that have since been significantly reconsidered by the evidence base. Asking for that review is not being difficult. It is being an informed patient. Fourth, if a transition is recommended by your physician, confirm the specific tapering schedule in writing. A responsible, evidence-based physician will reduce beta blockers gradually, typically over 4 to 8 weeks, and will monitor you carefully throughout the entire process. Do not accept "just stop taking it." That is not appropriate medical practice. Fifth, begin tracking your own symptoms right now, starting tonight. Keep a simple daily log. Write down your morning blood pressure reading. Rate your energy level on a scale of 1 to 10. If you are monitoring your blood sugar, include your fasting reading. 3 to 4 weeks of your own consistent, honest data gives your physician something concrete and specific to work with. It changes the nature of the conversation entirely and makes it far more productive for both of you. One critically important clarification before we close: there are absolutely patients for whom beta blockers remain the correct, appropriate, and genuinely beneficial medication. If you have coronary artery disease, a documented history of heart attack, diagnosed heart failure, or certain arrhythmias, including atrial fibrillation, the calculation is entirely different. The evidence base supporting beta blockers in those specific conditions is solid, well-established, and not in question. The concern we have discussed throughout this video applies specifically to seniors whose only diagnosis is hypertension, elevated, blood pressure without any accompanying cardiac condition. If that describes you, this conversation is absolutely worth having with your doctor at your earliest opportunity. Here is the bottom line that I want you to carry with you when you leave this video today. If your blood pressure medication is leaving you exhausted, if your weight is quietly creeping upward, if your blood sugar is trending in the wrong direction, if your energy feels like a fraction of what it used to be, and if that prescription has not been seriously reviewed in years, you now have the research, the clinical context, the specific language, and the exact questions to walk into that appointment differently. You do not have to simply accept a prescription that was written years ago as permanent. You are entitled to a treatment plan built on current evidence, not on decades-old habits and clinical inertia. You deserve better than that. Your health deserves better than that. Drop a comment right now and tell me, are you currently taking metoprolol, atenolol, or another beta blocker for your blood pressure? Just yes or no. I read every single comment, and your question may genuinely shape a future video on this channel. If someone you love is struggling with their blood pressure management or simply taking the same medication they have been on for years without anyone revisiting the decision, then please share this video with them today. One conversation, armed with the right information, can genuinely change outcomes. I am Dr. Alan Mandell. If this video gave you something useful, and I believe it did, please give it a like right now because it helps this information reach the seniors who need it most. Subscribe to this channel if you have not already and hit that notification bell because next week we are covering the silent mineral deficiency that makes blood pressure medications significantly less effective, and it is one that most doctors never think to test for. You will not want to miss that one. Take good care of yourselves. I will see you next week.